Thank you, Anirudh. Thank you, Vezomac, for having me here. And I think, Secretary VSI, first of all, I would like to congratulate each one of the Vezomac members. These theme-based meetings are very important, and we focus on some in-depth analysis of certain things which get missed in the annual conferences or even the midterm. So there is a small VSI happening here. Thank you, Vezomac. Thank you, Shekhar sir, and everyone from Vezomac for having us. So I'll be speaking on the drug-eluting stents. It's a vast topic, but some things have already been covered in the previous talk, so it makes things easier. Robbie sir was talking about some marriages, and I think that marriages with the drug-eluting technology, with a stent, it's a perfect marriage to sound, but well, everybody of us will agree there is no perfect marriage in this earth. So we'll talk about the designs. There are three components. One is the stent, then is the drug, and then is the polymer. That actually are the three things that are essential for the success of the stents designs that they have made. If the struts are thicker for having more drug, that makes it again in the long term not as useful. If the polymer is itself causing some problems, the shellolic acid, then they have the fluoropolymers, they have urea, then they have no polymers, and then gradually the terminology changed from a drug eluting stent to a drug coated stent. I'll come to that also. So these are the three things that are essential in the design of a stent, and all that my talk will have today is that Vivek sir does not like, but studies, and studies. The double-blind studies, which I don't think that have any meaning after Raghu sir's talk, and the RCTs that I don't know what it's actually measuring, but well, I have to talk about the stents and the data. So the Eluvia stent, which is right now available in India, the silver PTX, from where this story was, it picked up very well. It was measured with the bypass. Also, they had a randomization. They had long lesion. They had 1 year results, 3 year results, 5 year results. Then there was the Abbott Dynalink E, the sirolimus, the Cordis J&J that they started with, and the Nitidase, that's the LV Medica. I will come to the details of that. This had a drug, the limus, that was the amphilimus, which was sirolimus, plus a fatty acid that they had as the drug. The others, taxils and the limus, will come to that. So coronaries, from where this was picked up, actually where it all started, that okay, you have an anti-proliferative technology. In the FEMPOP, it's accelerated restenosis. Based on that, the Silver PTX first was approved in 2012. There was improved patency, freedom from TLR. That was the endpoint, suggesting incremental benefit over the, at that time, whatever larger studies were there were bare metal stents. And then came the Eluvia in 2018 that was approved. So this paper in 2024, JVS Vascular Insights, talks about drug coating and drug eluting, that Dr. Joy was talking, that without a polymer, it is actually a drug coating, not an eluting, because you need the elution to be happening at the time that Dr. Joy was saying, at 10 to 12 months. So Silver PTX did not have a polymer, and that was in fact the terminology. All the papers initially started with the drug eluting stents, but then they came out to a drug coated stent. So if you talk about the balloon, again the same thing. Can it be a DCB or a DEB? So you can't have a balloon which is eluting later on. It will be a coating that's there. So the terminology should be a DCB rather than a DEB. So peak incidence happens at 10 to 12 months that Dr. Joy showed. Eluting stents characterized by polymer coating, while without a coating, it is a drug coated stent which actually gives off the drug in maximum 60 days. Particularly advantageous in preventing restenosis. That is the time when the restenosis will occur at 10 to 12 months. So is it secreting the drug at that time? Is it eluting the drug at that time, or is it gone? So coated stent is polymer free, more rapid drug release, which may be beneficial in different clinical scenarios, but could also result in a shorter duration of the therapeutic effect. So this was in Vascular Insights, and when they did a study, that if you see the graph, as soon as the Eluvia was released, the drug coated stents started to coming down, and the drug eluting stents went up. So this is actually the transition happening for the Zilver PTX, when in 2018, the graph that you see coming down, actually that was the Zilver PTX, and the going up was the Eluvia in CLTI patients also, in diabetes patients also. This was the analysis that these people did in 2024. This was published just now. So Limus eluting stents, 2002, the Sirocco trial. The sirolimus coated smart stent, 6 months. I won't go too much into the details. All I want to highlight is just 36 patients were there in this trial, and they did not reach any statistical significance. Sirocco 2, they said, okay, let us continue the trial, let us come up with more data. The incident stenosis were 22.9 and 21%. So they said that they're lower but not significantly. What you see is 46 patients in the Sirocco 2 trial also. What previously was talked was that we need larger numbers to come at some conclusion, not these 30, 40 patients, but well, they paved the way for the larger studies. And every study that you will read, in the end, the disclaimer is that we need larger trial, we need larger trial. That is how every study has to end. So STRIDES trial, 104 patients. Everolimus drug-eluting stents, this came to the with the Limus technology. Overall results seemed very similar with the bare metal nitinol stents. Primary patency, 68% at 1 year. Elvemedica, polymer-free. Then again, this was a coated stent loaded with amphilimus, that is, I talked about the fatty acid. And then the 1 year, 2 year, the Illumina first in human study, that 24 months, the patency and freedom from TLR was 83% and 93%. They said, well, this is one of the good studies that they are having because the polymer is a little different, so that's why the drug is better off. Then the paclitaxel, they have made a lot of comparisons in the Cook made with the Zilver PTX versus POBA, Zilver PTX versus covered stent, Zilver PTX versus longer lesion, Zilver PTX versus bypass. So 1 year, the paclitaxel in the 2011, this study said that 1 year, Zilver PTX, superior 12-month event-free survival and primary patency, that was 83% versus 32%. That was just the POBA. So that was very significant at that time because 32 versus 83%. At 5-year data presented in Charing Cross at that time, we attended that. Some of my seniors would remember that, okay, this was being presented, that provided sustained safety and clinical durability that superseded POBA, said, okay, this is a good stent, this is a promising stent. Then came the battle trial, which said that with a mimetic stent, that was at that time the Supera they didn't have, but with the Misago BMS, they said that there was no difference in rates of instant restenosis at 1 year. Now this was a finding that again till 2 years they studied this and said maybe that the design of stent, and they said that if you have a stent that can sustain the SFA forces, may not need that drug technology at all. If you have a mimetic stent at that go, which is not exactly a bare metal stent but a vasculomimetic stent, so that then they started thinking more. They had this Zilver pass, which means Zilver with a bypass RCT. They had the comparison with surgery. They compared with surgical bypasses and thought that non-inferiority in terms of safety and efficacy, let's see. So at 1 year, primary patency somehow was almost same and statistically insignificant with a lower rate of perioperative complication and shorter hospital stay. Well, that was at 1 year, but the inclusion-exclusion criteria, if we go in detail, they said that it was almost similar at 1 year with a bypass. Imperial trial, eminent trial, Eluvia versus Zilver PTX, one-on-one. Dr. Joy was mentioning about the imminent trial. Then there was the Imperial trial and the Imperial long study. That was 3-year results they had published. So at 1 year, they said that improved primary patency with decreased major adverse event with Eluvia. Biomimetics, whether this addition of drug coating is really required with the current biomimetic stents and with a proper bed preparation, is that actually required? Eminent trial said that primary patency at 12 months was significantly improved in Eluvia stent arm. improved life dimensions. Now, this was important because they said that eminent trial also focuses on quality of life. Previously, everything was about the amputation-free survival, TLRs. Then they said, what about the quality of life, which should be matching the real-world scenario? And this eminent trial was the one which talked about the quality of life, pain-free survival, discomfort for a majority of patients without significant difference. Said that not too much of a difference. They found that, okay, both the stents are having almost same quality of life. So, question of long-term safety of paclitaxel coated devices that has been asked again and again, that whether they are safe, whether this elution going on, that Dr. Rahul asked that after 1 year, if this is eluting, that there are pockets there, if you are eluting a drug. So, they said that, okay, then this meta-analysis, the famous Constantinos pause that happened, was this study that is quoted below, that in 2016, after that, this was published in 2018 in Journal of American Heart Association. Then this said that the relationship was there with worse long-term survival compared with uncoated devices. Now, this is what every government had taken a cognizance of, and the US FDA said that use it with caution, use it only for highest risk of restenosis, do not use it routinely. And this was the US FDA warning in 2019, after which everybody, that was what Dr. Raghu was talking about, the long pause. Eluvia stent associated with accelerated development. So, as was talked, that everything that has been told to you, take it with a pinch of paclitaxel or a pinch of salt. Do not swallow anything and everything that has been given to you. So, this, as Paresh sir was asking, that accelerated development of aneurysmal degeneration, because there is a drug, the remodeling is not happening. The Devinder said, and Ilan sir talked about the the media degeneration that is happening. Sometimes that is what is termed as the halo sign, and halo sign was actually that came into picture in porcine models. Eluvia stent was found to be associated with aneurysmal degeneration in compared with Zilver PTX. So then there comes a drawback. As you go along the road, you find that there is no perfect marriage. Actually, that's what I was mentioning. And then further on, the imperial trial, the capsicum registry came, and then they said that whatever way they were finding that halo, they said, no, we are not finding the halo now. So, no difference in halo prevalence between Eluvia and Zilver PTX. Then they said USG follow-up to assess this endpoint was only available in 27% of the patients. And this study said, this imperial trial said that, okay, now they have studied only less than 30% and then said there is no difference. The rest of the 70% patients not studied. Capsicum registry said that fluoropolymer-based drug-eluting stents, this degeneration was noted to be as high as 16.8%. So this study again highlighted this problem of aneurysmal degeneration of the stented arteries, where there is drug elution happening actually, not the drug coating. Eminent trial, halo prevalence was not significantly different between the Eluvia and BMS cohort. That was non-significant. Aneurysm degeneration may be related to FEMPOP artery stents as a class, and that is association with meaningful clinical endpoints has not been established. That is after these studies were done, so that it does not go out of fashion. And that is the narrative that was given to I don't know, no offense meant to the industry, but to shove it off. Then in July 2023, the FDA reversed this restriction as several publications and large data sets ruled out this worse survival. So 2023, the FDA said, okay, this drug-eluting technology can be used, and this pause of 18 to 23 was taken off. That, okay, this can be used, but you have to have larger trials. That is what they said. Then this is the sports RCT. I came across many names, many different kind of names, capsicums and imperials and eminence and whatnot. Sports RCT was a Tepe et al. They said that DES with bare metal stent with a paclitaxel DCB. So all three arms they had in this sports RCT, and they have a 220 millimeter lesion. The mean lesion length was 220 that was there in this sports RCT. Eluvia provides superior performance versus nitinol stents and DCB measured angiographically by percentage diameter stenosis, late lumen loss at 12 months, because this was obviously eluting the drug by that time. So this RCT said that in long lesion lengths, this proved to be beneficial with regards to that. Eluvia provided superior outcomes versus these two technologies measured by freedom from TLR up to 12 months. So both in the diameter reduction and TLR in the long lesions, this Eluvia stent was fared better in this sports RCT. Then there was two more different names. Pardon me, sir, for so many trials, but I'll come to this thing. Drastico, Real PTX, single center RCT compared what? Silver PTX to DCB. The lesion length 146 to 140 mm. 1 year follow-up, DCBs not superior to Silver PTX. Another Real PTX RCT comparing PTX to DCB. Similar patency rates, non-significant trend in favor of DES. So controversies always existed. What I am trying to tell is that DES is not the perfect thing. As compared to DEB, the superiority has been questioned time and again. That is what I am trying to say here. ESPRIT trial 2016 Lammer, first in human study of drug-eluting bioresorbable scaffold. Then they said, let's not leave the stent inside. Deliver the drug and let it pass off. Let it get dissolved. As was said in the morning, that there are so many things, the nanoparticles, scavengers, various things to deliver the drug. So let's have a scaffold. For external iliac artery and the SFA, they devised this, and they said that 100 milligram of everolimus per centimeter square will be delivered as from the scaffold. Sustained patency 2 years. Freedom from binary restenosis 87.9%, 83.9% at 12 months and 24 months. But lesion length 35 mm. That is what this scaffold was designed for. So this is when you are reading in between the lines that, okay, you have a good patency rates, but then what are you dealing with? Ongoing trials, ANZ, April 2025, the results will be, the recruitment will be over of a eFemoral 1 trial and Disappear trial, which some things were presented in Charing Cross this year, which is a multicentric trial. eFemoral 1 is from 7 centers across Australia and New Zealand. Disappear has 18 centers across Europe and Australia. That is also a balloon expandable stent with a drug elution that is going to come, that the trials are just ongoing. So this was regarding the FEMPOP segment. I'll finish up the BTK segment. Sorry for just taking 3-4 more minutes, but well, drug eluting stents in one lecture I have to cover. So just so many stents, so many designs, Cypher Select, Zynes V, everything that you see here are coronary stents. The thing that you are seeing here is an extrapolation of the coronary technology into the BTK segment. And why? They are paclitaxel, everolimus, sirolimus, nitinol stents, stainless steel stents, everything. I'll come to that. But all the trials that have been done, Achilles, Yukon, PADDY trial, Seval trial, IDS trial, Life BTK trial, all these are made for the coronaries, extrapolated on the BTK arteries. Dr. Dhanesh will be talking specifically on his experience on the BTK stents. But if we see, the number of patients are in good range, 200, 140, 161, 137. All they talked about is maximum patency rates 6 months to 1 year, nothing beyond that. So everything that these things talk about, sirolimus, paclitaxel, everolimus, is maximum up to 1 year, nothing beyond that. So in 2 studies, we will see that in 2 trials, the primary endpoints were also not met. In the rest of them, the primary endpoints were met. So were these studies designed adequately? The Achilles trial, well, for exams, you used to study the Yukon and the Achilles trial. Some postgraduates will confer to that. Achilles trial, Cypher Select or POBA, this was the comparison. Drug eluting stent at 12 months achieved significantly lower restenosis rate. Need for repeat revascularization and amputation rates were similar for both the arms. Destiny trial, Zynes V, this is for the coronaries. 12 months, significantly improved. Drug eluting stent significantly reduced both instants. So every study that was being done at that time was saying that drug-eluting stents in the BTK segment is very good. Yukon trial, Yukon S stent versus bare metal stent, they said 12-month patency 80%, secondary patency 91% in the drug-eluting stent, also change in the classification grade. Paddy trial, which was the Texas Liberty, which was a balloon expandable, all these were balloon expandable stent, 5-year rates of amputation, event-free survival, lower in the DES arm. Now here is where these things start to change. Now this is that drug-eluting stents have lower the amputation-free survivals. Although the results of all previously described drug-eluting balloon expandable stents sound outstanding, the implementation of a permanent metallic scaffold in small caliber vessels could be considered an undesirable downside of this procedure, and that is how the narrative changed with the live BTK trial when they had a ESPRI BTK versus POBA. They said that primary efficacy composite endpoints was higher with the DES. Then came the PES. This is the self-expanding stents. All these stents were balloon mounted. Now this is the self-expanding stent. They said it failed to show a positive outcome with the drug-eluting stents in below the knee region. Sahu trial, 12-month primary patency rates were 68% and 76% for the POBA group. Now here POBA is primary patency is better than the stent group. So this is how the narrative starts to change once you have a landmark trial saying no, we were a little wrong because the lesion length was very small. I'll come to the lesion length, and no benefit related to effectiveness and safety with nitinol DES compared with POBA could thus be demonstrated. Concerns: lengths, coronary stents, short stents, cost. Okay, you are compared to a POBA, you are putting in stents, you may have to put 2 stents or 3 stents. Higher risk of crushing deformities, where all? In the distal half of tibials and in specific anatomical arches where the anterior tibial is perforating the intraosseous. Difficult arterial disease pattern, they say that it's a small arterial disease, medial calcification, big arterial disease with intra-arterial calcium, short length of coronary stents, crushability, flexibility is not there, permanent nature of DES, you are leaving in metal there, and lack of hard clinical outcome improvement. Is it healing the wound? Is the ischemic rest pain being relieved? Are the major amputation rates going down? Or you are just looking at patency? So these are the important drawbacks with relates to this, all these things. So this is regarding the lesion lengths. Only ideas, the bars that you see, the maroon bars that you see are actually the lesion lengths. Achilles, the mean lesion length in mm is 26, Destiny 15, Yukon 30, Paddy trial 21. Only Ideas has a 127 mm lesion length. Otherwise, all the trials are having 30, 40 lesion lengths stents that were used at that time. So what do we mean by that? That better sizing, optimal vessel preparation, maybe the technology improves, dedicated BTK debulking devices are there, plaque modification like we were talking about IVLs in below the knee segment, combination with appropriate, including bioresorbable scaffolds, and a shift towards limmer solution that sirolimus is gradually picking up, that these devices will hold promise in the near future. So to summarize, this is the giant wheels that are there, which I am not sure anybody will be able to crack this code, but if I am to say this, which I have studied, that if you see on the right, this is the FEMPOP segment, on the left, that is the BTK segment. In the FEMPOP segment, if you decode this graph, there are so many arrows running all over, some favoring the bare nitinol stent, some favoring the polymer based stent, some favoring going last towards plain balloon angioplasty also, or drug coated balloon. So there is a round robin happening on the right side. Left side, if you see the BTK, plain old balloon angioplasty, single wire, single balloon, or you go for spot stenting. In some cases, selected cases, this may help you if there are so many studies on the left side. You see Paddy trial, Sahu trial, they go for polymer based paclitaxel eluting stents, limus coated resorbable scaffold. So this all, if you go into the sub analysis, you may find your patient that you are treating. So there is no one size fits all that, okay, this is the technology for the future that has to happen. As we speak, the trials are still ongoing with relates to drug-eluting stents. So I hope that I have been able to decipher everything, and everything has been answered with regards to drug-eluting stents. We all understand everything with regards to the Bombay government that has been made. We understand the Maharashtra politics, and we understand drug-eluting stents. Thank you so much for understanding my pun and everything.
Thank you, sir.